At MSC Sleep, we pride ourselves on being a best-in-class CPAP provider. MSC has developed a standardized CPAP setup curriculum to ensure that all patients receive consistent, quality content along with the standardized visual aids and reference material. Whether set up in person or through a virtual platform, each patient is set up by a licensed respiratory therapist like me and receives the same content, information, and education. Our standardized curriculum goes well beyond simple device and mask training. Our clinicians provide information related to OSA and potential comorbidities associated with the disease, along with the tips to help patients acclimate to therapy, usage requirements, and how to contact an MSC sleep coach. Our proprietary standardized setup ensures consistency across all locations, driving high compliance across the patients we serve. Rest assured that a patient setup in Milwaukee gets the same quality setup as a patient setup in Buffalo. To learn more, please visit our website at medicalserviceco.com.
Good afternoon. I have the honor of introducing our next speaker, Dr. Eric Ye. Dr. Ye joined the University Hospital System in Cleveland, Ohio in October 2020 as a sleep specialist in the Division of Pulmonary, Critical Care, and Sleep Medicine. Originally from Taiwan, Dr. Ye grew up in Canada before earning a Bachelor of Science in Physics from the University of British Columbia in Vancouver, British Columbia, Canada. He then went to Beijing, China to earn his medical degree from Peking University Health Science Center. He completed his family medicine residency and sleep medicine fellowship at University Hospitals Cleveland Medical Center in association with Case Western Reserve University School of Medicine. Dr. Ye is board certified in family medicine and board eligible in sleep medicine. His special interests are enhancing PAP therapy compliance, alternative therapies for OSA, and inpatient sleep medicine. He is a member of the American Academy of Sleep Medicine and the American Academy of Family Medicine. Dr. Ye's research interests include convenient diagnostic tools and alternative treatments for OSA, epidemiology of sleep disorders across different specialties and the general population, as well as recognition and treatment of hypoventilation in the inpatient setting. We are grateful to have Dr. Ye participate in our education forum today and want to remind you that you can submit any questions you may have for Dr. Ye by using the Engage tab above the presentation screen. Dr. Ye will lecture on patience and perseverance. Sleep is right around the corner.
Hello, everyone. I guess welcome to the Medical Service Company 21st Annual Memorial Education Forum. I am Dr. Eric Ye. I'm a current practicing physician in sleep medicine with University Hospitals. You can see on my background on the left side, okay? And then I'm also an assistant professor with Case Western Reserve University School of Medicine. So I am gonna talk about a topic that's really dear and close to my heart as I begin to see more and more patients, and then with a little bit over 2 years of experience in sleep medicine, still fairly new to the field, but I have my take and then my observations to it. And I believe what we do together is very, very important. We are making a big and positive change in not only our patients' lives, also our patient's family, our patient's friend, our patient's neighborhood, our patient's workplace, and probably even right here within our city, within the state of Ohio even, or the entire country. If you really think about it, we're making a big difference by making just one person sleep better, one patient at a time. Because what happens when they sleep better? They're happier. They almost always are happier. And it's it's just so much joy to see so many happy people, and happy people have good consequences, which makes us a happy big family or big world, whatever you call it. So, but before we get there, we need what to focus on what I'm presenting today, which is patience and perseverance. We need patience to get there, and sleep is right around the corner. All right, I'm gonna go ahead and start off with today's presentation, and then here we go, and thank you for listening. So objectives today, I want everybody to recognize the importance of each step of this chain of care. And we want to identify factors associated with the reduced PAP adherence and implement interventions that can improve PAP adherence. In the beginning, we're going to talk about the adherence in CPAP and how much CPAP use is needed to improve for improvement in the OSA-related outcomes, factors associated with adherence, interventions to improve adherence, and finally, a systemic approach to improving CPAP adherence. So I'm going to pause right here. CPAP stands for constant positive airway pressure. And I promise you, by the end of this presentation, and I hope you carry that away with you, is that CPAP is going to carry a totally different meaning. So coming to here, is CPAP adherence really that bad? So we have some studies and some data that we pull from years ago. There are some that are more recent, but more or less is telling you the same. So studies dated back out here in 1992, 1994, 1996, going down to 2000, 2012, and all that. So you see the average number of hours of use going anywhere between 5, 6, even you see the best here with 6, and then you see a 5 down here, and then gradually go down to more like a 5, 4, and 3.5, 3.7. Why do you think that is? Oh, I will wait until you ask questions, and you can answer too at the very end when we have a Q&A session. Don't just have questions. You can answer what I'm asking right now. Why do you think the CPAP average number of hours of use seems to be decreasing over time? I do have a thought, but I don't know if that's why. Maybe just more people are using CPAP. I don't know. Is that what you think too? You might have other thoughts. You might be in this field a lot longer than I am. So definitely welcome to that discussion there, okay? So reported adherence over here. There are various different types of reporting adherence. And of course, now we'll be like, hey, we tell the patients, we're watching you, don't worry. We know you're using what you're not using. And we'll send you text messages. We'll send you emails to tell you, hey, you gotta get on your CPAP. You gotta start using whatnot. So we have a lot of objective monitoring. But sometimes those objective monitoring is not available. For example, sometimes I don't have the downloads available readily in front of me. So I ask patients, how much are you using? And generally, I use it every night. And more often than not, when I look and when I actually pull up the download after I receive it, maybe, a couple hours later or a day later, I was like, what, really? So generally, subjective reporting is overestimated, okay, by about an hour and plus or minus 2 hours or so. And 60% of them will say, I use it every night. And the mean duration is here. But granted that this is from a pretty old study, if you look at that in 1993. But regardless, the trend is still very similar. Self-reporting and subject reporting still tends to overestimate. So the overall adherence rates reported depends on what study you look. It ranges from 29 to 83%, to how adherent they are. And probably every practice will tell you something very different. And probably every DME company will tell you that their adherence is something different. Truth or not, it really is not the point here. The point here is that, okay, if we already have great adherence, that's good. But if we do not, how do we make it even better? Okay, so how do we measure? Obviously, great. The adherence that we're talking about with subjective reporting, objective reporting, objective monitoring, those are the things that how we measure. And why do we want to focus on that? Is that we have obviously a better data. Greater adherence is associated with better outcomes. And then we already talked about this. And then of course, the whole big sentence that we tell our patients, right? The insurance requirement. If you do not do this, your insurance will stop paying for you. And I'm gonna get back to that a little bit later on in my presentation. How that is a necessary statement, but probably most of us fall into that trap of not delivering that particular sentence or statement in an appropriate manner, okay? So example of good adherence, you look at that, this is from one of the old reports back with, with the old Respironics there, and you can see that, wow, it's agreeing all throughout. And then you see coming down here, oh, you see the spotty usage here and there, and usually, started going, okay, maybe I try a few days, try it a little bit, take it off, put it back on, take it off, put it back on. Getting it off, okay. And then try it again, can't use it. Oh, it's the weekend, not even gonna try it Monday, Tuesday. And I was like, maybe I should. And then this started getting longer and longer, as you say, 3 days without, 4 days without, 5 days without, and going forward. So commonly used tracking systems, as we know, Care Orchestrator with Respironics, and formerly is Encore Anywhere, although Care Orchestrator does look a lot better than Encore Anywhere. ResMed with AirView, then Fisher-Paykel, InfoSmartWeb. I pulled this up from somewhere. I have never personally used it, but it's out there. And but right now, most of the machine that we're seeing is still Respironics and Philips. And of course, some of them are coming up to the market and all that stuff, but it doesn't matter. But these are the systems that we use to track. And adherence of data derived from CPAP therapy tracking systems, more or less still the same. I know with AirSense 11, we got a little bit more data on the volumes and stuff like that. But regardless, what we really care about is, okay, how much are you using? And when you're using, how long are you using it for? And when you're using over time, how effective is the residual, it's the therapy for you. And then we try to use the residual AHI, the leak, the type of event to kind of identify that. Okay. So event detections, apnea, hypopnea, RERA, flow limitation, clear airway apnea, central apnea index, periodic bleeding. And then this is kind of a combination of what different brands of machine tracks, right? The Respironic track a certain way, the ResMed track a certain way. And we got the leak data, 95% leak, 95 percentile leak, max leak versus number of times of major leak or, whatnot, depends on what you're looking at, right? Respiratory flow data, and some might be able to even track heart rate, oxygen saturations and stuff like that. But most of the trackings that we're seeing is the top 3 over here. So we're gonna go over just a tad, and maybe many of you are already aware and are familiar with how they detect or how the machine detects these events, but we're just gonna go over them real quick. Don't wanna spend too much time the first part of my presentation because my heart and soul is rest with the second part. Okay, so hypopneas with ASMNO, with the decrease of flow by 30%, yada, yada, yada. ResMed, they have the hypopnea definitions, and I am not 100% certain if, with the AirSense 11 or with the DreamStation 2 or whatnot, if these definitions has been updated or not. But I believe that they're still mostly correct here, as you can see on the definition here. So that's just kind of like how they track and how it's a little bit different from each brand of CPAP machine, okay? Then we keep on going, apnea is how they tracked, but then again, apnea, to me, it's a lot clearer, basically just a high resistance, you just can't get through, that's apnea. So there is a lot less variable there because more than 90%, or the way ResMed does is a 2-second moving average root mean square ventilation falls to 25% of the long-term ventilation for more than 10 seconds. Raise your hand right now if you understand what that means. All right, I don't see any show of hands. Obviously I can't, but which means that it's kind of hard to understand, okay? But it's gone through some testing, gone through some validation. So though the data, in my opinion, is kind of here and there, but we just kind of have to take their word for it for now. Respironics, moving windows of 2 minutes, establish and flow decrease 20% or less of baseline airflow for 10 seconds. Regardless of these definitions here, the number you see is the number you see, and then that's what we really care about. But having the ability or having the resources to understand how they come up with that number, it's going to be helpful. Okay, regardless of what you're doing, what part of this chain of care are you at? Are you a doctor? Are you a respiratory therapist? Are you a nurse coordinator? Are you just a DME rep, a clinical liaison, whatever it may be? Knowing these basic terms and how they come from is going to be so helpful and it's going to help tremendously of explaining things to our patient and making it understandable to them, making it easy to comprehend. I don't know how many times that I have talked to my patient and actually sat down and explained in detail in a very quick way. I got my little own spiel of what AHI means. But once I did that, you're like, man, I've been an OSA patient using CPAP for 10 years. I have no idea what AHI means. It takes some explanation, it takes some education. And I hope that all of us understand that. So when they ask, we can explain to them in an appropriate way. So is an apnea obstructed or central? They have different approaches. Clear airway apnea from the respironic ones, if increased airflow, labeled as clear airway, obstructed airway apnea, periodic breathing, and ResMed's approach with the forced oscillation techniques, basically shoot something out and then to see if there's any responses. Central apnea, if there's any low resistance, obstructive apnea, if there's high resistance, unknown, we see that sometimes if there is a greater leak, or they just basically like, I don't know what this is, So it's important sometimes when you look at these data, don't get so scared or just go, oh my God, this residual AHI is 15, 18. Maybe 12 of them will be the so-called unknown. We gotta be able to learn how to read these reports and be able to help our patients to appropriately troubleshoot and furthermore, help them to increase their ability to adhere or be compliant with the therapy. Although just a personal note here, I hate the word compliant. Just almost feel like, are you complying with, what you're doing? Are you being a good patient and all that? We really ought to think of a better word. Are you so happy with your CPAP that you can't get off of it? Perhaps, I don't know, that sounds too many words, but regardless, the way we deliver these things, the way we deliver these information, how can we have our patients or your /customers being open to suggestions, being open to what we are trying to tell them, and to understand that all we're trying to do is to really to help you, but not to add an extra layer of requirement on it. Is the reported AHI a valid measure of PAP efficacy? Several studies use PAP AHI to follow clinically different AHI thresholds in different studies, but little peer-reviewed literature validating AHI. Conclusion is that with uncomplicated OSA, namely uncomplicated OSA, straightforward OSA, the patient's airway is like a floppy balloon every time they fall asleep. Every time they fall asleep. So what you do is you blow the balloon open with the PAP therapy, with the mask and everything, and put it on, and their balloon blow right open. That's uncomplicated OSA right there, all upper airway issue. Okay, AHI here, or namely the residual AHI, is a reasonable estimate of the treatment efficacy. Performance degrades for event detections with higher pressure levels. Remember that. At the higher pressure level, that residual AHI may not be as reliable as you want it to be. Better for detecting apneas than hypopneas. Low AHI of less than 10 is probably pretty good. High AHI of, greater than 10 or 15 or 25 is probably bad. Okay. Sometimes we, even as physicians, I get fooled by numbers, and I'm not gonna lie, I get fooled by numbers. When I see a number 4.8, how do I drive it down to 2.2? Although the patient is saying, I'm already 100% better, I'm living my life and I can't help it, but I need to switch up that setting just a tad. And I'm speaking to many of you who may be working in the sleep lab at night when you're doing the titration. Oh my God, I'm seeing a hypopnea, 1 hypopnea, 2 hypopnea. All right, let's turn it up. When in doubt, pressurize, right? But then is that really the right thing to do? Or can we wait for a little bit and see if the patient reacts well to the titration? All right. Understanding leak. So what is it? What is the leak? This is a pretty old picture of the intentional leak with that little tip up there, but most of the intentional leak right now, obviously I got some of these, right, with the little holes around here. Those are the intentional leaks, and different type of mass has different intentional leak. Like right here, you can see some intentional leaks over here. These are intentional leaks to create a better seal. But if the leak coming from here, the leak coming from the mass itself, on the side, oh my God, it's blowing in my eye. Oh my God, it's coming down my chin. Those are intentional leaks. So we got a total leak here, obviously, is unintentional leak plus intentional leak. Simple math, right? So understand that leak is mass and pressure dependent. Oral mask or full face mask is more likely to give you a higher leak. Higher pressure is more likely to give you a higher leak. It is just what it is. And the reason, and then the way I explain to my patients, I don't know if you've never done that or ever thought about that. And then it's nice to have these things around. So let me pull this up so that this presentation is not too boring. You get to see somebody over the video, but still trying to entertain you as much as I can. So when we put this on, put it out like that, right? How much circumference do we have? The longer the circumference, the longer the circumference, the more chances there is to leak. It's probability, it's chance, right? More places where the seal can be broken and the leak can come out. A smaller mass like that, and of course, I actually personally really like these new under the nose ones, but this one is still with the pillow on top. I'm so sorry, I can see that. Okay, with the pillow on top. Okay, so put it on like that, going that. Not much circumference, extra circumference for the leak to occur. Just isn't. So there you have it. The answer is really easy, right? So full face mask, more likely to have higher leaks, and nasal mask or nasal pillow mask, they're less likely. And when you have higher pressure, higher leaks, not hard to understand that. So the idea here is, and then we'll get to that later on, if we can get by with the lower pressure and get by with the smaller mask, in my opinion, I think we should try every endeavor, everything at our disposal to try to help our patient to achieve that. So when the report leaks in different ways, I'm not gonna go into the details here, but just wanna tell you, hey, the question is right there on the right. Which threshold is right? We don't have a clear data and we still don't. Okay, how much CPAP use is needed for improvement in OSA related outcomes? When you see that right over here, less than 2 hours, this percentage within the normal values, 2 to 4 hours, 4 to 5 hours, 5 to 6 hours, 6 to 7 hours, more than 7 hours, you have that MSLT, basically more and more in that normal part. And the biggest thing here is the excessive daytime sleepiness. But this has also everything to do with the quality of these common questionnaires that we use, to evaluate the patient progress and everything. But the story is clear here. The more you use, the better you're gonna feel. but don't ever forget, I always tell my patient, and the some of the things I'm repeating here, I think it would be very, very helpful. It really doesn't matter what your role is when, the ones that are listening to this presentation right now, whether you being in the sleep lab or you being, at a DME company, helping patients. These little things, if we can repeat that over and over and over from different people, it's really going to help our patients to remember, oh yeah, doctor said that. And this guy at this company said that. And that, wonderful technologist who helped me at night during my sleep study also said the same thing. One of the big thing here is not only the night of CPAP use, hours of nightly use, 6 to 7 hours or greater than 7 hours or whatnot. This also corresponds in some way how much patient sleeps. CPAP, the idea really is to improve the quality of sleep, right? A more consolidated, not interrupted sleep because of the respiratory event causing arousal, even going to waking, and then make people think that I'm just old. I need to go to the bathroom 7 times a night. That's just me. I'm getting old. No, right? So when we take that out, the quality of sleep improves, but quality never replaces quantity. Regardless how old you are, regardless how, younger people, I'm talking about 10 years and younger, you need longer sleep time. And teenagers, you need longer sleep time. But basically 18 and above, 7 to 9 hours, all the way until 18 and above. So all the way until you're 81, 181, doesn't matter how old you are, 7 to 9 hours. That is still the recommended for everybody. Okay, so you still need to sleep. CPAP adherence and measurements of sleepiness. You guys, some of the testing here with the NWT multiple wakefulness test, mean to normal values and the choice average reaction time and, executive maze time and all that. But regardless, everything is showing that if you can use it more and at the same time sleep more, adequate sleep, you are going to perform better overall. CPAP adherence and incident for hypertension and CVD events for non-sleepy OSA patients, meaning they're not really symptomatic. But we got more data on cardiovascular events. However, I'm not going to address that today, but with hypertension and the control of hypertension, CPAP is still very, very useful. And again, I also want to take this chance to instill in your mind, it's not really the numbers that we're looking at. It's not the magic 120 over 80. It's not even the magic of 140 over 90. It's about if they have uncontrolled hypertension, what happens next? You could have a stroke because of that. You could have, your vision could go all the way bad because of that. You can, faint because of that. You could have a stroke. You could have a heart attack. Like all kinds of things, all the bad things that are related to uncontrolled hypertension. And we have a very effective therapy here, not only to take care of patients of their, let's say, subjective sleepiness, but also to help them to effectively lower their blood pressure. So factors associated with adherence, what's going on here? So let's look. Associated with reduced adherence, lower socioeconomic status, nocturia, you had a stroke, increased nasal resistance, initial degree of hypersomnolence, poor coping skills, reduced self-efficacy, claustrophobia, and you're less sleepy. You're not that symptomatic to begin with. A lot of times I ask my patient, okay, after the whole thing, and I say, wait, why did you come here? Why did you seek out a consultation with the sleep doctor? And then the patient just kind of, I was like, wait, what's going on? And then, I get this one probably the most. Yeah, my wife is not sleeping in the same room with me anymore. I was like, oh, okay. Is it because you're snoring bad? It's like, yeah, my snoring, she won't even sleep on the same floor with me. She has to go down to the basement. I was like, okay, so that's really get you treated, but they are probably not sleepy at all. The severity of OSA has nothing to do with your sleepiness, quite strangely. But doesn't matter, severe, mild, or a mild, moderate, severe, it really doesn't correlate to your sleepiness. But CPAP adherence. So conflicting data on adherence, CPAP pressure level, age, gender, side effects, BMI, AHI severity, they're conflicting data and all that stuff. So anyway, let's keep on going. Consistent versus intermittent users, you'll see that, the data is kind of showing initially they might use it more and then they might use it less, because some people actually come back and tell me, say, hey, before I need to sleep 8 hours and still not feeling refreshed, now I'm sleeping 6 hours and I'm good to go. And sometimes I don't know what to say to that, quite honestly. I mean, I still would love that they would sleep 7 hours, but, I will pick my battles, one battle at a time. So those ones I usually congratulate them. They have great CPAP adherence. I love it that they're feeling good. But over time, this is kind of the trend that you see. But you can see the consistent users, they are generally tend to do better. So here comes a very important part. All right. So use at day 3 or day 7 predicts use at day 30. What does that mean? That means that initially, in the very beginning, if they start off on the wrong foot, it's really hard to get them back. So my job is important. Your job is even more important. The very first time, the very, very, very first time you meet CPAP, or you have met CPAP before, or you have met PAP therapy before, you have met the mask before, and then, sorry, I'm really personify these ones because I really think that they will become our patient's lifelong friend, but I'm really hoping to facilitate a good relationship between CPAP or /CPAP mask and my patient and our patients, okay? So in the very beginning, you gotta get everything right. Not necessarily perfect, but at least make an effort, and then I think we all do. At different different spots or different parts of the chain of care, we all need to emphasize that and put our shoulders in and really help our patients to start off right. A good start is half of the battle. So a good CPAP mask fitting session, and I understand during the COVID time is difficult, but we try to do it over Zoom or whatnot, but regardless, that's really important. As sleep labs, really find a way to let them try and let them see how many different kind of masks there is, because interface is 80% of 80% of everything. You're okay with the, mask, you're pretty much okay with the therapy, right? Because that's how the therapy gets delivered to you. And in the very beginning, please, CPAP desensitization to everyone. Yes, I said that. CPAP desensitization to everyone. It's so important. It's so important that we tell our patients that getting on CPAP, it is not, I say it again, important things I say 3 times, it is not an intuitive therapy. It is not a tablet. It is not a medication where you just hop it in and gone. You be able to see things happen. No, it takes time. Okay, it takes patience. All right, and on average, patient takes about 3 to 6 weeks to get used to the therapy and reiterate that, so that patients will have realistic expectations. So when the rubber hits the road, they know they're expecting some bumps along the way. They're expecting this. When they're expecting this, they're less likely to give up. Okay, so it's so important in the beginning. We want to make sure that, hey, at day 3, day 7, these are the very beginning. Okay. And I want to say this probably right at this, and I might emphasize it again at the end of the presentation, is that I know it's important to tell them you have to use 4 hours a night. You have to use more than 70% of the time, 20 waiting days out of 30 days. And then that's the only way the insurance will continue to pay for you. But trust me, when patients hear about money, they forget about how sleepy they feel. They are so afraid of paying things out of pocket. Oh my goodness, $50 a month. And I'm totally saying the truth right here. They hear that a lot more than they hear, oh, it will take 3 to 6 weeks to get used to. They are so afraid of that. And I know everybody's doing their job, saying the things that they're supposed to say, but there is a good way that we can deliver it right. I always tell my patients, go at your own pace. The first couple of days, the first week, the first 2 weeks. And I hope that, we can be on the same mentality. I mean, yes, I agree that eventually they will need to be compliant. The rule is a rule. But in the beginning, I think the emphasis really should be on trying it on 20 minutes a night, 30 minutes a night, or something like that. And don't even be stressed over about it. It's the killer of sleep. Stress and sleep, they don't go together. They go opposite ways. All right. Sorry, I spent a lot of time on this slide. I tried to fly through the next couple ones, but this is where I really care. I mean, I can't emphasize enough how important it is to have a good beginning with the CPAP and be available to them. When they have questions, when they have issues, be available to them so that they can get it fixed. Sometimes it's just that the other day I saw a patient like this. It's unbelievable. This doesn't even fit. He has his mask like this. It's upside down. I don't know how it happened. It's upside down, and then somehow, it worked with the full face mask there. I think it was the AirFit F20 or something. But anyway, things happen. We need to be available to them, and hopefully we can. And hopefully we can find the right way to do it. Okay, so let's continue on. And let's see, early predictors here, obviously problems first night. Okay. Recent life events, things happen. People give up, people do this, people do that. That's okay. All right. But then that stresses again how important it is to start off with the right foot. Okay. Or start off right. Side effects associated with CPAP, interface, mask leak, skin abrasions, conjunctivitis, claustrophobia, insomnia. Oh my God. You put the CPAP on me. I can't sleep like this. How do you expect me to sleep like this? And then they get more stressed out. They can't even fall asleep. But why don't we just let them try a couple nights without going to sleep with it? Learn to breathe with it. All right. Pressure related, you see all this thing down here, equipment related, the noise, the smell, the tubing, the spousal intolerance, the ramp abuse, keep on hitting, start from the beginning, start from 4. I can only take 4. Many of those is lack of practice in the beginning, lack of that getting used to period. I am going to sleep with it all night right now, first night. And I'm sorry, I'm going to tell you, not going to happen. Not now, not ever. People need acclimation periods. People really do. And yes, you say, oh, yeah, there's somebody. Yeah, I get it, but they're the lucky ones. And our job is to help the unlucky ones. And I hope that we all see that together, because we got to do it together. It's not just me, not just you, but we got to do it together. Okay? So interventions to improve adherence. Here we go. Heater humidifications. That's give them the right tube. Please, let's give them the right tube. I don't know what the price difference is, but let's give them the right tube. Let's give them the tube that actually hooks up to the heater humidification part, not just a normal tube, please. The recommendation is based on a 3 levels. I study here and there, but anyway, 3 level 1 studies, my bad. And there's 1 level 2 studies, whatnot, but there is indicated to improve CPAP utilization. Difference in outcome and measures between CPAP use with heated humidity or with cold passover humidity versus without humidity. And the result is pretty clear there. Mass interface. Look at all that. This is not the most updated pictures because of namely the newest under the nose nasal mask. Those are the ones that I feel like most of the people actually tolerate it really well. The Dreamwear under the nose, or the N30 or the N30i, whatnot from ResMed. I'm not sure if Visual Pico is the same thing or not, but regardless, you know what I'm talking about. Different kind of masks, big or small, tube coming from the top, tube coming from the, coming from the top, coming from the front, all kinds of different masks out there, right? The 3 main categories, that's what it is. Choosing a right one is so important for them. Full face versus nasal mask. Sorry, I don't have an actual full face. I understand we call this the full face, but this is more like an oral, in a way. But then we see all these nasal mask versus face mask. It's 5.3 versus 4.3 hours per night. There's a study about 20 years ago, but now it's probably even better. The excessive daytime sleepiness changes. Nasal mask versus full face mask, 8.2 versus 9.8. 19 out of 20 express preference for nasal mask. But is it easy to fit a full face, a nasal mask or a nasal pillow mask? No, it's not. You have to teach them how to breathe the new way. We are so used to, and probably me and you included, so used to breathe with our mouth open. And many times when we hear patients say, oh my God, I'm a mouth breather, I'm a mouth breather, I'm a mouth breather. Okay, full face mask for you. But why don't, are we able to spend extra 2 to 5 minutes or something like that and just walk it through with them and tell them, yeah, you're going to experience this. You're going to breathe in with your nose and breathe out with your nose. And you might even find this, when you try to breathe out, you feel the air is trying to come out of your mouth like this. And show it to them. Take down your mask just for a quick second and demonstrate it to them. You're going to feel like this. And then when they're really trying at night, they're like, exactly, that's what my doctor told me. That's what my therapist told me. That's what my liaison told me. And they see it, they know it, they expect it to happen. When they expect it to happen, they're mentally prepared to counter. Okay, anyway. Caution about full face masks. You know, there's a thing called MAT, mandibular advancement therapy. That's what we call oral appliance. The idea of that is what? To push your bottom jaw out, right? I see on the side, can you see me? Push your bottom jaw out so that what? You can have your tongue kind of rest down at a good place. What's a full face mask do? Especially if you pull the back, you know, the under the ear strap real tight. You're gonna push it back in. Counterintuitive, right? So be careful with the full face mask. I'm not saying it has no utility. Some patients still do, but then that's really try. Bottom line, nasal mask should be considered first line. Nasal pillow may be more acceptable, more accepted as the time goes on as well. Many people like them, but there's also people who don't, you know, which everybody is different. Mask is such a personal thing. Full face mask might be considered if excessive dryness occurs, just because, you know, sometimes you still don't have that good seal because of the dryness. Having some leak from the mouth open, I'm totally fine with that. You know, that's not a bad thing, not necessarily a bad thing. But if it considers, and then if it causes, you know, extreme dryness, then it will be hard. And we got this. Teach people how to put it on appropriately. Show them how to put it on. This is actually not that intuitive. The first couple of times I tried to do it, I actually put it upside down or like backwards. This is not that easy to put, not that easy to learn either. So show them, really demonstrate. Okay, if you can, you know, hopefully. Oral mask can be effective alternative, okay? All right, I really gotta speed up. Education and CBT, I think we had got a lot of that. Group CPT, CBT, we are not in a good environment to do that just yet, but going forward, and hopefully we can all partner up, hospitals, care systems, DMEs, the sleep labs, all get together, somehow provide personnel, provide bodies to help. If we can have a session of an hour, teaching 10, 15 patients all at the same time, imagine how effective that will be. Even just showing what I just did to you guys, you know, just showing that in front of them makes a world of difference. Peer buddy systems, group education system, automated telemedicine, trying to get back to them and remind them and tell them, and sometimes even scare them. Oh my God, if you don't use it, your blood pressure is gonna go crazy. And believe me, I've been there, done that, okay? But I think what really is that people with sleep problems, they are frustrated, they're scared, they need a lot of TLC, they really do, all right? And you and I are the one to deliver it. Unfortunately, we are. That's what we sign up for. And let's go get them. PAP nap. You know, you can suggest that too. Sometimes they just have great deal of difficulty. Tell them to call us. We schedule a PAP nap for them to come in to actually spend more time and actually take a nap, or try to actually, you know, just have a more dedicated time for them. I understand time is precious to every one of us. Time is precious to you. Time is precious to me. We sometimes don't have the time we just simply do not have the time to spend that much time with the patients. But, the important thing is you can always squeeze out that little bit of time, even just 2 minutes, just pick one little bullet that you have and throw it to them. You still gotta sleep more, or be patient with it. Sometimes they just need a little bit more reassurance. Okay. Patients offer sleep testings and CPAP titration if indicated. If reluctance, then an app is offered. Approach with mass and pressure desensitization slowly, one step at a time, kind of getting it forward. And this is proven to be really helpful. PAP test results, obviously they're helpful results. That's why I posted them here. Just when you kind of find out with your patients, you can suggest them, hey, talk to your sleep doc. We can get them a PAP now. Bilevel PAP versus CPAP. As far as effectiveness is concerned, probably not that big of a deal. I mean, not that big of a difference, actually. And then what it is that if they have problem with CPAP intolerance, sometimes that EPAP is just way too high for them to breathe out against. BiPAP may be an alternate, reasonable alternative. Okay. CPAP should be considered first-line therapy. Bilevel ventilation is not superior to CPAP, but maybe as effective as CPAP. Okay. Obesity hyperventilation is a different deal. Okay. But then over here, we're talking about OSA. There may be a subpopulation intolerant to CPAP that may benefit from a bilevel ventilation, i.e. BiPAP, or bilevel positive airway pressure. We still need more studies to talk about this. Pressure relief CPAP, which is the EPR or the A-flex or the C-flex. And this is becoming very, very common right now. More study would be needed about this to really define the potential target populations. And sometimes, in my understanding, in plain simple words, I'm making CPAP a mini BiPAP, and it's really more for tolerance purposes. Okay. Auto CPAP. I don't think we really see things other than auto CPAP anymore. I used to, even just a couple years ago. But regardless, there are some devices that would not titrate beyond 10 centimeters water if apnea present due to a concern of central sleep apnea. And again, I don't believe it's the machine that we're using right now, but with central sleep apnea, you really should not be treating it with auto CPAP unless, you gotta be careful with that. But, we're here to help with that, how to adjust that purposely, but appropriately or trial. Lower mean pressure for night may improve adherence over the long term. And remember that, if you have something about 4 to 15, and then patient actually needs it only around 6 or 7 most of the night during their REM period. So when they're on their back, they might need 10, they might need 12. Okay, we give them that pressure. So they're not on 10 all the time. And remember, in the very beginning of my presentation, leak is proportional, is dependent on pressure. Okay, so the lower the better, in my opinion. CPAP versus auto PAP adherence, there is a little bit better adherence with the auto CPAP, but again, there are more studies coming out and then talking about this as well. Okay, but regardless, there's really no point comparing it too much right now, but just to in the back of your head, because sometimes we will still revert patients back to fixed CPAP for different issues. But those are the things that you can know and learn and be okay with it. Be ready to deliver that suggestion. Sometimes, go back to see your doctor to see if you need another titration study. Auto CPAP is not a solution to everything. It's a very convenient solution, but it's not a solution to everything. So we got this study, which I'm not gonna dive into here, but regardless, we'll talk about this auto CPAP versus CPAP, and then I want to get to the bottom line right here that auto CPAP works at least as well as conventional CPAP, and there appears to be a general preference. Non-adherent patients may be good candidates for CPAP, but require further investigations. I would say even more non-adherent patients will be good candidates for our extra effort. Medications. Yes, we can give them some medications sometimes because sleep is very complicated. And then this is more for, if we have any physicians or fellows on this call, or nurse practitioners, we could try to use that to help them to adhere better. And although nocturnal awakening wise, none of these sleep aids are superior to CPAP therapy, and we should be aware of that. And then we don't want them to get, constantly be on this and be dependent on this. But in the beginning, sometimes I do too, just to help you to get used to, and with the aim to get you off of it at some point. So Zolpidem too, over here, it's got all this. A systematic approach to improving CPAP. I really gotta fly through this. Assess and enhance patient readiness. I have said that all before. Are they ready for this therapy? Are they ready for you? Are they ready for this new friend of theirs? Okay. Manage expectations. Important. 3 to 6 weeks is at the very minimum of people getting used to CPAP. And consider smaller goals. My goal is very small, 20 minutes first night. That's always what I tell my patients. 20 minutes first night. Patients should identify rewards for using CPAP. Ask them, did it feel better? Did it not? Have them be honest with you. Identify barriers using CPAP and address them. Insomnia, anxiety, nose issue, dryness, mask. Mask is a big one. All right, so we got a little bit example of problems and problem solutions, and you probably have all these somewhere in your desk or in your computer. Make use of that. Read them, understand them. Monitor the dashboard, use of the cloud, bring problematic patients back in with early several weeks. I have my patients 4 weeks, 6 weeks, 8 weeks, and 3 months, depending on my initial feeling if they are gonna have trouble with CPAP. I do bring them back pretty early just to make sure that we get them. And then we address the problems early on. Consider group educational efforts. Refer to behavioral psychologists for CBTs. Consider implementing other modalities. Follow up. They really need our help. Okay, like I said, CPAP is not intuitive. All right, lastly, sleep is the multifaceted phenomenon. Everything affects sleep. Each one of us has an important role to make the life of our patients' family, then friends, and world better. We gotta see the big picture here. Making one person sleep better, making one person's life better is going to eventually somehow, with the butterfly effect, make your life better as well. Believe me, you are going to get rewarded, please. You are going to get rewarded. You may not see it right now. You may be like, what do you mean you can use the full face? What? No. Like, what do you mean you can use the nasal mask, nasal pillow mask? Just to put the full face on, it's fun. End of the story. Get out of here. No, let's try a little bit harder. Breathe with them. Okay. Do not underestimate that extra 2 to 5 minutes that you spend with your patients and your customers. Offer your helping hands and loving heart, not just to go through the motions, okay? And again, I say, great care that we deliver together as a team. Great care takes a village. Takes the doctors, takes you name it, everybody. You included, all right? Our patient depends on you. Their happiness, their satisfaction, their quality of life depends on you. Lastly, let me get that. So I said I'll come back to you. What does CPAP really stand for? Does it still stand for constant positive airway pressure? My version is constant, patience, and perseverance. And believe me, sleep is right around the corner. If we all chip in a little bit at a time, we'll get there. So real quick summary, close follow-up with patients within the first 2 weeks. Objective adherence monitoring is essential. Address side effects early on. Minimum number of hours on CPAP remains unknown, like exactly how many. But again, quality does not replace quantity. You gotta sleep. Consider the implementation of interventions discussed today, okay? And that's the end. Thank you very much. And I hope you enjoyed today's forum. And I guess we will have some question and answering time.